This is a flipped classroom pre-session podcast on neuromuscular blocking drugs and coexisting diseases. It is designed to provide foundational knowledge to be viewed before our active learning session. As an outline, we will talk about diseases and conditions, specifically extra-junctional receptors in burns, upper motor neuron and lower motor neuron lesions, cirrhosis, renal failure, differentiate between myasthenia gravis and myasthenic syndrome, multiple sclerosis and cerebral palsy, and then some special clinical situations such as the neonate and the elderly and those with increased intracranial pressure or increased intraocular pressure, and neuromuscular blocking agents. Let's first look at extra-junctional receptors. These receptors that increase in numbers and proliferate beyond the neuromuscular junction out on the muscle membrane do so after upper motor neuron and lower motor neuron lesions, muscle diseases, and in burn patients. As you can see, these extra-junctional receptors have 5 subunits. One subunit is different from the normal postjunctional receptor. These extra-junctional receptors stay open longer. They're responsive to both acetylcholine and succinylcholine. They have a short half-life, and when succinylcholine binds to them, they open and potassium is released and hyperkalemic arrest can occur. Hyperkalemic response to succinylcholine when extra-junctional receptors are present can occur under certain disease conditions and states: muscular dystrophy, burns, Guillain-Barré syndrome, severe chronic infections such as tetanus and botulism, the patient who is hemiplegic or quadriplegic when succinylcholine is administered, and even in immobilized patients such as in the critical care who have been laying in bed for an extended period of time. Let's look at burns. In burns, there is a proliferation of extra-junctional receptors. If succinylcholine is administered to a burn patient sometime in the 24 to 48 hours after the burn injury, when postjunctional receptors, specifically extra-junctional receptors, have upregulated, succinylcholine can cause hyperkalemia. The risk ends when healing of the burns occurs, but this may be months to years after the burn, and oftentimes succinylcholine is just simply avoided in patients who have been severely burned in the past. Non-depolarizers, however, like rocuronium, demonstrate resistance in patients that are burned. It takes larger doses to have the same effect. In cirrhosis, there is an increased volume of distribution for the non-depolarizers to go into. Non-depolarizing neuromuscular blocking agents are ionized, water-soluble molecules, large molecules that go into the water space of the body. There's a larger volume of distribution, therefore a larger initial dose is required to produce the similar plasma concentration, i.e. speed of onset and depth of block. However, if that large dose is administered to get that speed of onset and depth of block rapidly, that dose may hang around for a very long period of time, especially if the liver is involved in its elimination. Succinylcholine is not contraindicated in patients with cirrhosis. However, the liver produces many proteins, including plasma cholinesterase or pseudocholinesterase. If there is severe decreases in the protein pseudocholinesterase in the blood, the administration of succinylcholine may result in a prolonged effect, but this liver disease has to be severe for it to occur. When someone has cirrhosis, cisatracurium may be the neuromuscular blocking drug of choice because it has organ-independent elimination. Elimination is independent of both the liver and the kidney. In the case of renal failure and neuromuscular blocking agents, again, succinylcholine is not contraindicated. However, it is important that you know the potassium level, because a patient with renal failure may present with a high potassium, especially if they have not been hemodialyzed for some time, and succinylcholine will cause the usual slight increase in plasma potassium of approximately 0.5, and if someone started at 6 or 6.5, this may be enough to cause problems. The increased duration of action of most neuromuscular blocking agents occurs because the kidney is involved in the elimination of most of the neuromuscular blocking agents, at least to some extent. However, cystathric is one of the exceptions in that, again, it has organ-independent elimination, both the kidney and the liver. It breaks down spontaneously. Recurrization is unlikely in patients with renal failure, as neostigmine metabolism, as well as the breakdown of rock uranium and other non-depolarizers, is prolonged. The worry is that you may reverse someone at the end of a case, have that patient go fully reversed to the recovery room, for example, and then over time, because the kidney is not getting rid of the non-depolarizing neuromuscular blocking agent, it continues to be present, but the neostigmine could be metabolized, and then the patient have return of neuromuscular blockade. This does not appear to be a worry because neostigmine metabolism is also prolonged. What about myasthenia gravis and myasthenic syndrome? First of all, remember that myasthenia gravis is a post-junctional problem, while myasthenic syndrome is a pre-junctional problem. Myasthenia gravis is the patient often with antibodies to the post-junctional receptor. These post-junctional acetylcholine receptors are destroyed, and these patients will get very weak as they exercise. They're very sensitive to non-depolarizers because there's not many receptors post-junctionally that rock uranium, for example, would have to compete with to cause neuromuscular blockade. However, they are resistant to succinylcholine. Remember, succinylcholine requires receptors to bind to post-junctionally, open them, and cause a different type of block than does the non-depolarizers. Interestingly, if the patient is taking pyridostigmine, that is the myasthenic patient, because pyridostigmine inhibits acetylcholinesterase and will raise acetylcholine levels in the blood and potentially improve the symptoms of myasthenia gravis. If they're on that drug also inhibits plasma cholinesterase, and therefore the enzyme that breaks down acetylcholine, that is succinylcholine, may be affected, and it may offset this resistance. Myasthenic syndrome improves with exercise. It is a pre-junctional disease, and sensitivity to both succinylcholine and non-depolarizers tend to be present. Muscular dystrophy. Years ago, a black box warning from the FDA came out because many anesthesiologists were using succinylcholine routinely with children, and there were children who possibly may not had walked yet and just hadn't been diagnosed with muscular dystrophy, although had it, and when succinylcholine was administered, hyperkalemic arrest occurred. Succinylcholine is contraindicated in muscular dystrophy because of this hyperkalemic response, as well as rhabdomyolysis, which is possible afterwards. Non-depolarizers, unpredictable. There's case reports of normal response and some case reports of increased sensitivity. The main point being muscular dystrophy, don't give succinylcholine. As a side point, patients with Duchenne's muscular dystrophy are probably no more susceptible to MH than the rest of the population. In the past, there's been a worry that DMD, Duchenne's muscular dystrophy patients, are MH susceptible. Myotonia and neuromuscular blocking agents. Myotonia is when there is an abnormal delay in muscle relaxation. The pathophysiology is not the neuromuscular junction, it is the muscle itself. If you give succinylcholine to a myotonic patient, it may cause fasciculations of the muscles and contracture. It stimulates them to contract and not relax, and you may not even be able to ventilate the patient. So it's best to avoid succinylcholine. Non-depolarizers, somewhat unpredictable, but if a patient has myotonic contracture, realize that non-depolarizers will not relax a myotonic contracture because the problem, again, is in the muscle itself, not in the neuromuscular junction. Multiple sclerosis, ALS, and neuromuscular blocking agents. Multiple sclerosis is a progressive neurologic denervating disease, and if you administer succinylcholine, you may have a hyperkalemic response. That's the major point with multiple sclerosis. They may be sensitive to non-depolarizers also. Amyotrophic lateral sclerosis, or Lou Gehrig's disease, has degeneration of upper motor neuron and lower motor neurons, and succinylcholine can result also in hyperkalemic response, and they also may be sensitive to non-depolarizers. The main point, though, is avoid succinylcholine in multiple sclerosis and ALS, progressive neurologic diseases, as opposed to cerebral palsy, which is a static neurologic disease in which succinylcholine is not contraindicated and actually may be desirable in patients with severe GE reflux. For example, the cerebral palsy patient coming down for Nissen fundoplication or some surgery like that. They may show resistance to non-depolarizers, but may also have prolonged recovery from neuromuscular blockade. The major point in cerebral palsy is that succinylcholine is not contraindicated. What about various age groups and neuromuscular blocking agents? First, the neonates. Shortly after birth, the neonate is known to have increased sensitivity, a pharmacodynamic effect, more sensitive to neuromuscular blocking agents. But also neonates have a large water space or volume of distribution for the neuromuscular blocking agent to distribute into. So these kind of balance each other out. One, you give a drug that's diluted out more, but it's the patient is more sensitive to it. And so there's not much change that has to be made in the dosing of non-depolarizers. Succinylcholine is not routinely used in kids because of the risk of MH and also the risk of hyperkalemic response in patients with undiagnosed neuromuscular diseases. The initial dose, however, often needs to be increased because of their volume of distribution, and the succinylcholine dose may be increased to 1.5 to 2 milligrams per kilogram from 1 milligram per kilogram. The elderly are not more sensitive to neuromuscular blocking agents, so the reason why we often reduce the dose of neuromuscular blocking agents in the elderly is not because their muscles are more sensitive, but because their organs of elimination of the drug, the kidneys and the liver, may not be working as well, and you may have a prolongation of the effect of the neuromuscular blocking agent. What about those with increased intracranial pressure or intraocular pressure? The graph on the top right shows mean intracranial pressure and time after succinylcholine administered at time 0, and you can see small changes in intracranial pressure. And Sux may slightly increase intracranial pressure. Some have suggested the mechanism is increased afferentation signals from the fasciculating muscle to the brain and increased cerebral blood flow, cerebral metabolism. But inadequate anesthesia when you perform laryngoscopy or not ventilating properly and allowing CO2 to rise or hypoxia to occur are much more cause of increase in intracranial pressure than is succinylcholine. So Sux is not absolutely contraindicated for patients with increased intracranial pressure. Intraocular pressure, the graphic on the bottom right shows intraocular pressure on the y-axis and time on the x-axis after succinylcholine administration in an animal model with extraocular muscles removed from around the eye. And you can see that there is a slight increase in intraocular pressure for a very short period of time. And this is not blocked by defasciculating doses of non-depolarizers prior to succinylcholine. However, as you can see, this is a small increase for a very short period of time, and succinylcholine is not absolutely contraindicated even for open eye injuries, as there's little evidence that it increases chance of blindness or extrusion of eye content. However, if the surgery was going to be extended period of time and you needed to rapid sequence a patient, rocuronium is often chosen for this. So in summary, the next two slides are from Morgan and McHale's Clinical Anesthesiology 5th edition, which I think provides a good summary. Pediatric patients, succinylcholine is not used routinely. Non-depolarizing agents may have a little faster onset. Vecuronium tends to act like pancuronium in neonates, long action. Elderly, they have a decreased clearance. Their kidneys and livers may not be working quite as well, and cisatracurium, because of its organ-independent elimination, may be a good choice. With hepatic disease, remember there's an increased volume and distribution, and the initial dose may need to be increased. However, the elimination may be prolonged, except cystatricurium, which is unchanged. Pseudocholinesterase, the protein enzyme made by the liver, if it's greatly decreased in amount, can prolong the action of succinylcholine. Kidney failure, vecuronium is prolonged. Rocuronium is relatively unchanged. Cystatricurium may be the safest alternative because of its organ-independent elimination. And those that are critically ill, if they're immobilized for an extended period of time, can have a hypercholic response to succinylcholine, and if administered non-depolarizers for an extended period of time, i.e. for keeping a patient immobile while they're mechanically ventilated, can result in changes in the muscle, myopathy, polyneuropathies, and that's called critical illness myopathy, neuropathy after neuromuscular blocking agents. Looking at some of the diseases now, ALS, remember that they can have response to succinylcholine of hyperkalemic response. Burn injuries can have a hyperkalemic response and show resistance to non-depolarizers. Cerebral palsy, there is no contraindication to succinylcholine. Guillain-Barré can have a hyperkalemic response. Upper motor neuron and lower motor neuron lesions can have a hyperkalemic response. Muscular dystrophy can have a hyperkalemic response. And remember the difference between myasthenia gravis and myasthenia syndrome. The myasthenia gravis patient who has antibodies to the post-junctional receptor can be resistant to succinylcholine, but very sensitive to the non-depolarizers like rocuronium. In the myasthenic syndrome, however, is sensitive to both non-depolarizers and depolarizers. The myotonic patient, where the disease is in the muscle itself, can have generalized muscle contractions to succinylcholine, even impeding ventilation, while the response to non-depolarizers may be variable. This ends the short pre-flipped classroom podcast to provide some foundational knowledge so that when we have our active classroom time, we can have a discussion of cases and problems and questions and a deeper understanding of how diseases and conditions impact what neuromuscular blocking drugs we choose and how we use those. Thank you very much. This is a picture from the Dolomites of Italy from 2015, a wonderful bicycle trip. Have a good one.